Hello and welcome to the case-based educational curriculum in emergency medicine for Cambodia. Today we'll be talking to providers at Level 1 hospitals regarding adults with pneumonia. In this presentation, we would like you to keep in mind two facts about pneumonia, which is also abbreviated PNA. The first is that you can come up with a diagnosis without labs or x-rays in nearly all cases. The second is that we'd like you to keep in mind the treatment for pneumonia, which is oxygen, IV fluids given rapidly in boluses, and antibiotics. The differential for dyspnea, the main complaint that patients with pneumonia will present with, is broad. Dyspnea can be caused, as you know, by pleural effusion, reactive airway, or pneumonia. A far less common cause of dyspnea is pulmonary edema and heart failure. The other three causes of dyspnea, of shortness of breath, are far more common than heart failure. When you have a patient arrive who is sick with pneumonia, keep in mind that the treatment of pneumonia in this case, patients with hypotension and pneumonia simultaneously, is bolus IV fluid. When a patient presents who is sick with pneumonia and hypotension, the treatment is boluses of IV fluid given rapidly, 2 liters in the first 30 minutes after the patient arrives in the hospital. Here we see the case, a 45-year-old woman who presents with dyspnea. Notice how rapidly she is breathing. Also notice that she is diaphoretic. The first question that we would like you to think about is, what are 6 vital signs you need to know now when a patient arrives with dyspnea, breathing rapidly? There are 6 vital signs that you want to know: the respiratory rate, oxygen saturation, heart rate, blood pressure, temperature, and degree of pain. The normal values for those 6 vital signs appear on the screen. This patient has a respiratory rate of 44. As you can see from the video, that means the patient is tachypnic. First, oxygen saturation is assessed at the fingertip. Then, the patient's blood pressure is taken at the right arm. Heart rate is assessed by pressing 2 fingers against the radial artery. As you can see, this patient is very sick, with a rapid heart rate and an oxygen saturation in the mid-70s, which is declining rapidly. The patient's temperature is taken at the axilla. And finally, we ask the patient what degree of pain she has. From taking the vital signs, here we can see the vital signs that we observed. The oxygen saturation is 75%. The heart rate is 113. The patient is hypoxic with an oxygen saturation of 75%, tachycardic with a heart rate in the 1-teens. The blood pressure is 80/50, which is low, hypotensive, and the patient is febrile. The degree of pain is minimal. What this means is that the patient is very sick and will require rapid assessment, rapid care, and then reassessment and retreatment. For the tachypnea and the hypoxia, the patient needs oxygen immediately. A face mask is most appropriate in these cases of severe hypoxia. It is also helpful in many cases to sit the patient up. As you can see, after only a few minutes on oxygen, the hypoxia decreases significantly. After 5 minutes, the patient had an oxygen saturation of 95%, well within normal limits. Question: this sick patient arrived 5 minutes before your shift ends. How quickly should you be at the bedside? Within 1 minute after the patient receives their vital signs? Within 10 minutes? Within 2 hours? Or should the patient be seen by the next physician as soon as that physician arrives? The answer is that the patient should be seen immediately, within 1 minute after their vital signs are found to be sick, hypoxic, tachycardic, hypotensive, or febrile. In this case, the patient has all 5 indications for immediate treatment. Question: how do we address the patient's tachycardia and hypotension? Answer: in almost all cases, we should give the patient 2 liters of IV fluid within 30 minutes. The patient should receive boluses of IV fluid. What is a bolus? A bolus is a large quantity of medication given rapidly. Looking at the potential causes for the patient's dyspnea: pneumonia, pleural effusion, reactive airway, or heart failure with pulmonary edema. We can see from this chart that in most cases, rapid IV fluid is beneficial. And the history and physical will help us make the diagnosis and guide our treatment further. To reiterate, IV fluid given rapidly is essential for pneumonia, especially when a patient is tachycardic and hypotensive. In cases of pleural effusion and reactive airway, it may be beneficial and is unlikely to cause any harm. So let's begin to take a history from the patient. What are 10 questions that you want to ask this patient, at whose bedside you find yourself within 1 minute of their arrival in your emergency department? First, to determine if they may have the symptoms of pneumonia, we should ask how long they have felt ill, whether they have experienced fevers, chills, sweats, or if they have a cough. In this case, the patient has been ill for 4 days, with a fever, with chills, with sweats, and with a cough. Overall, the patient's symptoms, the patient's history, is consistent with pneumonia. We should also ask about pleural effusion, which in most cases is caused by tuberculosis. Does the patient have hemoptysis? Is the patient coughing up blood? In this case, no. Has the patient been on medications for 6 months? Yes, but not a tuberculosis medication. Has the patient ever been told they have tuberculosis? No. Do they live or work with anybody with a chronic cough? No. And have they lost weight unexpectedly? No. In this case, the patient does not have a history, does not have symptoms that are consistent with pleural effusion. Could the patient have a reactive airway? Are they wheezing? They don't know what wheezing is. Do they take inhalers? No. Have they ever smoked? Yes. So, because of their history of tobacco use, it is possible that the patient has symptoms consistent with a reactive airway. The patient may have asthma or COPD. Finally, regarding heart failure and pulmonary edema, we should ask these questions. Have they gained weight unexpectedly? No. Do they have leg swelling? No. And do they have a frothy cough? No. In short, the patient has no story, no symptoms that are consistent with heart failure or pulmonary edema. Attempt to summarize the information you know about the patient now. The patient is 45 years old and female. Their vital signs are tachypnic and hypoxic, tachycardic and hypotensive, and febrile. The patient is sick. The patient has had 4 days of fevers, chills, sweats, and cough. No symptoms have lasted months. The patient is a smoker and has no leg swelling or weight gain. The history is consistent with pneumonia and may be consistent with reactive airway, but is not consistent with pleural effusion and is not consistent with heart failure or pulmonary edema. A physical is still necessary to know what treatment to give the patient. However, in both cases that may be present in this patient, reactive airway and pneumonia, boluses of IV fluid will prove beneficial. Talking with the patient about their past medical history, we learned that they were previously healthy. Now, in any patient that you may begin medications in, it is important to ask if they have any allergic reactions to medication. In this case, the patient had a rash to penicillin in the past, and their past medical history is notable for the absence of liver disease. The patient is febrile. Fever means pneumonia is more likely than reactive airway. Further, the patient has a fever and no liver disease. So we have a question. What additional treatment should you give the patient now? We initially gave oxygen, but the patient has a fever. We should give the patient paracetamol to help reduce the fever in the patient. We know it is safe because the patient has no liver disease. Now going on to the physical exam, the purpose of which, in our case, is to confirm a diagnosis that we already have a strong suspicion for based solely on the history we took from the patient. At this point, the patient is more likely to have pneumonia than reactive airway, and almost certainly does not have pulmonary edema and heart failure, and almost certainly does not have a pleural effusion. We can see the patient is talking, so the airway is intact. After giving oxygen, the patient has improved O2 levels, but continues to breathe rapidly. The patient still has tachypnea. A full physical exam is important in all patients. We've reassessed the old vitals, but it is very important to listen to the chest in 6 locations, 3 on the left and 3 on the right, in order to determine whether or not individual lobes, 3 on the right and 2 on the left, may have isolated disease, such as a lobar pneumonia. You may also percuss to determine if a pleural effusion may be present. Please see the video on pleural effusions for more information. From the physical examination of the respiratory system, we learned that the patient has an intact airway because they are able to talk. Our reassessment of their vital signs shows that the oxygen has improved their hypoxia, but they remain tachypnic. The patient has right lower lobe crackles, no dullness to percussion, and no wheezing. So the exam is consistent with pneumonia, but not consistent with reactive airway, not consistent with pleural effusion, and not consistent with heart failure or pulmonary edema. Now let's assess the circulatory system. The blood pressure is low, 84/54. Listening to the heart, it is very important to listen to all 4 areas in a thorough exam. Each area focuses upon a particular valve. The patient is receiving an axillary exam here, and now a reassessment of their heart rate by checking again their radial pulses. You may also assess cap refill. Press on the patient's skin and see if the color returns in less than 3 seconds. If not, if it takes 3 seconds or longer for the blood to return, the patient has a perfusion deficit and may need fluids rapidly. You can also check for jugular venous distension, a sign of CHF, and for edema of the lower extremities. In this case, the patient has no edema of the lower extremities, but pressing on their skin shows that the capillary refill takes 4 seconds. Summarizing what we've learned from the circulatory exam, the patient has an improved heart rate but is still tachycardic and definitely remains hypotensive. The patient has a regular rhythm with no murmurs, rubs, or gallops. The patient has thready radial pulses, cool hands, and a 4-second cap refill, all abnormal. The patient has no jugular venous distension and no lower extremity edema. As you can see, the patient has signs of being very sick. The patient has a tachycardic heart rate and is very hypotensive. The patient needs IV fluid boluses given rapidly. Every exam should be complete, in that every physical exam that you do on a patient should include listening to their lungs, listening to their heart, and examining their belly. First with auscultation of all 4 quadrants, and then pressing on all 4 quadrants, superficial and then deep, to determine if the patient has, for example, hepatomegaly, splenomegaly, or any significant pain. In this case, the patient has a flat, non-tender, non-distended abdomen. There is no hepatosplenomegaly present, no edema, and no ascites. Summarizing what we know about the patient from their physical exam, we can add the following. The patient has improved tachypnea and hypoxia, improved tachycardia, and remains hypotensive and febrile. The right lower lobe crackles without agophony and without wheezing and without any jugular venous distension or edema are most consistent with pneumonia. Looking at the chart, we see that the history and the physical are only consistent with the diagnosis of pneumonia. The treatment is boluses of IV fluid because the patient has hypotension. Again, based on the history and physical alone, we know the diagnosis of pneumonia. The patient is tachycardic and hypotensive. The treatment is rapid boluses of IV fluid. In addition to this, the patient has pneumonia, fever, tachycardia, hypotension. The patient needs to receive antibiotics immediately. The boluses of IV fluid, 2 liters, should be given over 30 minutes. The patient is in septic shock. And this rapid fluid will, in most cases, be one of the most life-saving interventions you can do as a physician. The infection itself needs to be addressed. Ceftriaxone, 1 gram IV now and daily, is an excellent choice. Patients with an allergy to penicillin will not have any more reaction to a cephalosporin than they would to any other medication. It is safe to give ceftriaxone to patients who have an allergy to penicillin. Let's reassess the patient and see how they responded to receiving oxygen, IV fluid in rapid boluses, and antibiotics. The patient's blood pressure improved to normal limits. The oxygen is also within normal limits, but the patient remains tachycardic and tachypnic. The patient has a diagnosis and has received a treatment for that diagnosis. Where should the patient go next? If the vital signs are normal after our intervention, the patient should go to the ICU. The patient is very sick. Initially came in with septic shock, and so will continue to need antibiotics and fluids to maintain their blood pressure and ultimately to defeat and to kill the infection causing their disease. What if the patient's vital signs remain abnormal? Then the patient should be transported to a level 3 center as soon as possible via ambulance. If the patient is hypoxic, the reason for transport is so they can receive other interventions like CPAP, BiPAP, and maybe even intubation. If the patient is hypotensive, the reason to transfer is for the patient to receive IV fluid even more rapidly and potentially pressors such as dopamine or norepinephrine. The patient should be transported via ambulance with a face mask set at 15 liters, sufficient oxygen to maintain that face mask for the entire length of the journey, and while in transport, the patient should be bolused 2 liters of IV fluid, and potentially more if the journey lasts more than 30 minutes. So dyspnea has a very broad differential. And yet despite that broad differential, with a history and physical, we were able to come up with a proper diagnosis, treatment, and disposition without any labs and also without any x-rays. At the Level 3 Center, the physicians confirmed your diagnosis of pneumonia. As you can see on the x-ray, there is a right lower lobe pneumonia, which you heard auscultating the patient's lungs. In addition, the labs confirmed your diagnosis. The patient has a leukocytosis of 21, consistent with infection. The patient has renal insufficiency, likely because of the low blood pressure caused by the pneumonia, leading to septic shock. The patient also happened to have a very low platelet count. Most patients with pneumonia do not have thrombocytopenia, but in this case, the patient did, a sign of severe infection. The rest of the basic metabolic panel and CBC obtained for the patient is shown on the screen. So let's summarize. First, you can obtain an accurate diagnosis of pneumonia from the history and physical alone. Second, the treatment of pneumonia is 3 different interventions. First, it is important to give oxygen to all patients with pneumonia, but especially those who are hypoxic. Second, patients should receive boluses of IV fluid, 2 liters within 30 minutes, if they have a low blood pressure, if they are hypotensive, if they are in shock. Finally, patients with pneumonia need to receive antibiotics within the first hour of their arrival. In nearly all cases, ceftriaxone 1 gram IV is the proper medication to give patients with pneumonia. Thank you for listening to this lecture on pneumonia in adults for Level 1 centers.